All right, so we'll go ahead and get started with another case presentation series today. So once again, a reminder about the AMSSM Library of Sports Ultrasound Pathology. This is a very great opportunity to take the pathology that you see in clinic, the training room, or the sidelines, and actually turn this into a publication. This is also a great way for residents, fellows, and staff to add to the growing case series of the Library of Sports Medicine, Ultrasound Pathology, and also get a peer-reviewed reference for your CV. So more information for this can be found at the AMSSM webpage under the Sports Ultrasound tab. And then also you can always then email Josh Romero as well too. Otherwise, then going to be introducing the speakers for today's ultrasound case series presentation. So our first presenter is going to be Maddie McLachlan. So she was born and raised in Northern Michigan and earned her BA from St. Olaf College in Minnesota. She then attended Drexel University in Philadelphia for biomedical studies post-baccalaureate program prior to West Virginia for medical school. And then she did her family medicine training at Mayo Clinic in Rochester, Minnesota, and then is currently finishing her primary care sports medicine fellowship at the University of Iowa. And then our second presenter for today is going to be Jen Cogburn. So she's originally from the Pacific Northwest. She did her medical school at the University of Washington, and then family medicine residency at the University of Colorado. And she as well is currently doing her sports medicine fellowship at the University of Iowa. And together they're going to be presenting a case on snapping iliopsoas tendon.
Can you hear everything?
Yep, that's perfect.
All right, great. So I'm Jen. Nice to meet everyone. So yes, me and Maddie will be doing a snapping hip case. We'll get started here. So we don't have any disclosures, but we just wanted to say special thanks to Dr. Ryan Cruz and Dr. Derek Hall for their help with helping to create this presentation. And we just want to say that we're pretty grateful for all their teaching they provided us this year and to get to work with them on a daily basis. So pretty unique. So we'll get forward here. Objectives of this presentation is just to go over a brief case presentation. We'll go over the presentation of the scanning protocol for the anterior hip and relevant structures. We will review any the ultrasound images of the protocol for this patient. We'll review pertinent pathology and expand the differential. And then, of course, at the end, we'll review the final ultrasound report. So our case is a 32-year-old female who's a former collegiate downhill skier. She was presenting in clinic with right anterior hip pain, accompanied by a clunking sensation and a pop that was painful. This had been an insidious onset, no specific injuries or trauma recently related to this. Described the pain as deep and achy within the anterior groin, and the sensation and the pain was worse with hip flexion. They would get a frequent painful popping sensation with hip flexion and extension. Their physical exam was notable for a grossly normal appearing anterior hip. They were tendered up palpation in the anterior hip over the iliopsoas tendon and non-tender laterally. They have pain with hip internal rotation and log roll, and then they had an audible and palpable snap when you would move the patient from a flexed abducted and external rotation, also known as Faber position, into an extended adducted internal rotation. This is the patient's x-ray. So you can see here that they have some coxa profunda, they have some crossover sign, and that they also have some signs of cam morphology on the done view. Also have ischial spine signs, so they have signs of some borderline hip dysplasia and also femoral FAI or femoral acetabular impingement. So just things that we were thinking about going into the scan. Here's the anterior hip scanning protocol. So we'll go through the femoral head, neck, and capsule and the anterior synovial recess. We'll look at the hip joint assessment for fusion. We'll look at the labrum. We'll look at the femoral vessels and the nerve. We'll look at the iliopsoas muscle tendon bursa. We'll look at the Sartorius and TFL. We'll look at the rectus femoris tendons, and then we'll look for a dynamic scanning of the snapping hip. Below are the optional structures, but we didn't look at any of these relevant to this case. Here's just a really brief anatomy review of the anterior hip. So we'll be looking at majority of these structures, so the iliacus and psoas major forming the iliopsoas complex. We'll look at the anterior hip musculature. Other structures you could look at, and medial adductors if you're suspicious for any pathology there, and laterally as well. So here's the beginning of the scan. So we start in a long axis plane with the transducer, the patient in supine position, and we translate proximally towards the hip. And so this is kind of like the starting place that we start for any anterior hip protocol. Here you can see the yellow arrows are pointing to the hip capsule, and the red arrows pointing to where the anterior synovial recess is. This is where you would look for signs of hip effusion. And just to note too that there's the double layer of the capsule there, so could be pitfalls just for injections, so make sure you're looking for elevation of the capsule with your injections, but no effusion here, so pretty normal scan. So move up, we'll translate proximally to look here for the anterior labrum, which is the hyperechoic fibrocardial lattice structure here, triangular structure. You want to make sure that you're looking at the whole complex, so you scan medially and laterally to get the whole view of the labrum. There's a lot of anatomic variability here, and there's not any well-defined like guidelines as to calling or overcalling or undercalling a labral tear. But you can look for secondary signs such as associated fluids, cysts, etc. Other things, you can look at the hyaline cartilage of the femoral head here, look for any OCDs or look for any irregularities there. And then also look for paralabral cysts, as we spoke of. And then any like hypoechoic clefts or anything concerning for a tear. Then you just translate a little more proximally. This is in a short axis plane. You'll get to see the nerve, artery, and vein. So navel, as we remember from medical school, moving from lateral to medial. And as you can see, you just translate low proximally. You can start to see the iliopsoas tendon coming into view here with the iliacus muscle fibers laterally. If you're, I guess, ever concerned, you're not sure which one is the artery or vein. Obviously, artery is the pulsatile one, and the vein is the collapsible one. And then one of the optional structures, but we looked at was the pectineus muscle. So to get here, you can kind of, once you get to the vessel, you can just translate your transducer a little medially along the acetabular ridge, and you can get to the pubic symphysis or the pubic tubercle where the adductor tendons are asserting, and this kind of wag your transducer up and down looking for the muscle fibers of the pectineus. It creates kind of like a sling, you could say, under the neurovascular structures. So that's how you can be sure that you're looking at that muscle. Now I'm gonna pass the next to Maddie.
Okay, moving on to the iliopsoas muscle, tendon, and bursa. The image on the left is going to be important moving on when we're doing the actual dynamic portion of the scan, because as the patient kind of flexes and does that Faber position, it can be kind of disorienting. There's lots of moving muscles. So this left image for orientation, laterals to the left, and it's highlighting the nature of the pelvis and that it's pretty concave. And then you start to appreciate that there are like three kind of distinct muscle bellies. And then looking over to that little cartoon image, cross sections A and B, superior and inferior to the AIIS. And then at those levels, the purple correlates with the lateral fibers the iliacus fibers, and then the orange is the medial iliac fibers. And then the red is more of the psoas major muscle fibers. And so those together form the iliopsoas tendon, and that's kind of outlined here in this yellow oval, and it's sitting on top of this, the more linear hyperechoic structure inferiorly is the superior pubic rami. The image on the right is a long axis showing the iliopsoas tendon as it's coursing over the femoral head. And things to point out, you know, pertinent anatomy or potential spots around the iliopsoas. There can be a bursa, and then there's not one in this image specifically, but it would lift that tendon up superiorly off the superior pubic rami. And then the fluid could trace more medially around it. And that can be important, you know, hopefully in the anterior hip scan, we would have noticed if there was an effusion in the hip joint, but there can be a communication between that bursa and the hip joint itself. And the blue, that tiny little blue guy, he is the ilioinfratrochanteric muscle. But the main point of that is that there are 3 distinct muscle bellies that we would be kind of visualizing in that home base image. Next, looking at Sartorius muscle and tendon. The easiest place to find this is starting at its origin up at the ASIS. And if you just come distally right off of that, medially will be the Sartorius and short axis, which is the image on the left. And we're somewhere in between ASIS superiorly and AIIS inferiorly. And this is, you know, when you can see this structure distally or caudally, you'll start to appreciate the direct of the rectus femoris tendon coming into view. And the right image is showing Sartorius and long axis. You're just rotating the transducer to try to get those fibers in kind of a more long axis orientation. Sartorius is kind of a weird muscle in that it kind of makes like that S shape. So kind of optimizing your image there, and then keeping in mind that depending on the patient population, if this is a pediatrics, there can be cortical irregularities at the ASIS. There can be, you know, the traction apophysitis. There can be avulsion fractures, stuff like that, which is then, you know, highlighting the benefits of ultrasound in that you can just scan the contralateral hip to see if there is actually any widening at the apophysitis or the apophysis there. For TFL muscle and tendon, again, your kind of home base is the ASIS, and if you're come just distal to that and lateral, you'll start to appreciate the TFL. And in short axis, it's kind of a stout muscle, and then distally, it'll kind of blend into the IT band. The right image is showing the TFL in long axis at the level of the ASIS. And then moving on to rectus femoris muscle and tendon. Everyone's aware there's a direct and indirect head, but that can be a little bit challenging for imaging. In terms of the direct head, the origin is at the AIIS. So that's this image here in long axis with proximal on the left and distal on the right. Important to not overcall pathology in this region, particularly. That hypoechoic area is representing the indirect head, and that is important to kind of recognize because it's going to make a pretty deep kind of aggressive turn posteriorly to attach onto the superior ridge of the acetabulum, and some of those fibers like blend into the joint capsule itself. If you keep that center on this image before, if you center that hypoechoic area and then translate in this like coronally oblique plane to bring into the long axis view of the indirect head of the rectus femoris as it kind of inserts into the hip joint itself. This image itself is showing a labral tear with a small paralabral cyst. And that image is from Dr. Hall. That wasn't specifically from our case itself. And then the image on the right is the short axis view of the rectus femoris, and this is highlighting that the indirect head continues to form the central tendon, with the direct head forming the peripheral muscle around it. So this is our video. We'll play it a couple different times. There's a lot going on in the beginning, so bear with us as the patient comes up into that Faber position. And then ultimately, there's that dyskinetic motion down there. We'll play that again. So there's this cartoon image on the right side that I think is a little bit easier to understand because there's quite a bit of motion going on throughout that patient positioning. And basically when the patient is up in the Faber position, the iliopsoas tendon, which is here, is going to roll out laterally over those medial iliacus fibers. And then it kind of gets hung up superiorly a bit. And then as the patient returns to the neutral position, the tendon moves medial and posterior as the muscle can kind of get, it's not entrapped in this view at all, but it can get hung up there, and it should be like this smooth rolling, and it's not smooth in this case. And then it abruptly kind of comes back into its position, and it kind of lands on the superior pubic rami. And because we talked about that concavity of the pelvis, it kind of acts as like this echo chamber, and it amplifies the sound. And so that's the snapping sensation and the clunk that can be quite loud for patients. So pertinent pathology for snapping hip, creating the differential. If you don't, obviously have it on the differential, you're not going to make the diagnosis. And I found that the adolescent females I have seen with this, the snapping sensation can be kind of like alarming to them, and it's often described as like their hip dislocating. And so it's hard for them to articulate exactly where this is happening, right? So whether it's actually truly intra-articular, like a hip joint problem, and then whether it's snapping internal, external, posterior, lateral, stuff like that. So in terms of intra-articular hip problems, you can have a labral tear or a paralabral cyst that can cause snapping. There can be a loose body. There can be synovial proliferative disorders. In terms of snapping, internal snapping, most commonly, like in this case, it's due to the iliopsoas tendon itself, and it's a failure of the psoas muscle to roll smoothly over those medial iliac fibers, and then it snaps posteriorly and medially back into position over the superior pubic rami. You can have a bifid psoas tendon that can cause issues. You can have iliopsoas snapping over AIIS a bit distally. You can have subluxation of the indirect head. And then I did see a couple of cases where iliopsoas snapping over a pretty large cam morphology. And this patient has bilateral cam morphology. So that could be, we were able to visualize the exact pathology, but that is one to keep in mind for internal sources of snapping hip. In terms of external, it's mainly a problem of the greater trochanter. And so it's either the IT band or those anterior band of the Gmax over the trochanter that is the problem. And then posteriorly, ischiofemoral impingement or proximal hamstring subluxation can be problems as well. And so these are a few companion cases, kind of helping you remember to keep a broad differential. And like we talked about, the loose bodies in this anterior recess of the hip joint itself can be a problem and can be a source of anterior snapping, as can a paralabral cyst that extends. In this case, actually, you can see this anechoic area into the iliac muscle itself. The sonopalpation, you can see movement of that fluid, and then an acetabular labral tear in this area with anechoic stripe superiorly. And then out laterally, pause, there's a lot going on. We talked about how the IT band can snap over the greater trochanter in this image or video, and then posteriorly the quadratus femoris snapping over the ischiofemoral space can also be a source of posterior and lateral snapping hip. So finally, ideally, we're able to articulate everything that we just found into words, what we're seeing. So this is a chronic, an evaluation for chronic right anterior hip pain, and specifically for snapping. Our findings for the anterior hip joint, there is no synovial hypertrophy or effusion within the anterior recess. The hip labrum didn't have any tear, cleft, or paralabral cyst. And then the iliopsoas complex itself had normal echo texture without any thickening, tear, or effusion. We talked about how there can be a bursa. This one did not have any iliopsoas bursitis or bursa fluid. The dynamic flexion testing in the Faber position revealed a dyskinetic movement of the iliopsoas tendon as the hip was brought back into the neutral position. the medial iliac muscle was noted to suddenly release out laterally as that tendon abruptly returned to its position medial and deep to the muscle at the level of the superior pubic rami. This motion correlated with the patient's snap and their pain. And then the rectus femoris tendon, there's the direct head, had normal echo texture without any thickening or tear. And then the indirect head was within normal limits in terms of Sartorius and TFL, normal echo texture without any thickening or tear. And then our summary section, hopefully is a bit more concise than that paragraph above for the iliopsoas complex, and you're trying to communicate, specifically answering the question that the referring provider gave to you. So in this kind of, in a brief way, we're saying that the dynamic evaluation reveals dyskinetic motion of the iliopsoas tendon complex consistent with internal snapping hip syndrome. There was no evidence of significant iliopsoas tendinitis or tendinosis or tear, and then no fluid in the iliopsoas bursa itself. And that's what we have.
All right. Thank you so much, Jen, Maddie. That was obviously a great presentation with some phenomenal images. So as far as, kind of comments and questions, just kind of a few quick things that I'll kind of bring up and mention. These are usually, fun cases, because a lot of the other imaging modalities, obviously with it being kind of a dynamic process, that you're really relying on the ultrasound for these cases. And I would say from the dynamic nature, for the snapping iliopsoas, you guys had mentioned kind of the maneuver. The best thing to do for these cases is going to be that flexion, abduction, external, rotation. Then it's usually then kind of going into that extension. But on occasion, I will say you kind of have to get a little bit unique, and some of these patients, can, have a specific way that they can recreate those symptoms. And so sometimes you just are going to have to kind of, work with the patient, whether it is going to be in the supine position, or, sometimes it can even be, standing, and just trying to modify it just so that they can actually get that recreation of that snapping sensation. One other kind of pitfall that I'll say, at least for, starting to scan with these, especially with the dynamic nature of it, is that I will say sometimes increasing the kind of depth, and I think you guys demonstrated that pretty well with your video, because sometimes when you're going into that flexion position, you can kind of increase the depth there at the hip. And so kind of doing that will give you a little bit broader, field of view, and really trying to, capture the actual snapping as it kind of goes back down into the extension. The other things you guys had mentioned in the differentials, or kind of, part of this process, as far as the snapping iliopsoas, is that, you can have a bifid iliopsoas tendon. I think it's in the literature, usually those are going to be less than 20% of cases. But just to be aware that you can have that bifid nature. However, I will say, I think with the literature and some of the cases seen as well too, it seems like more often than not, some of those bifid cases, the patients will actually be more symptomatic, just because this is, once again, one of those processes that you can capture it, but it doesn't always mean that it's going to be obviously recreating those symptoms. And the other, as you guys had mentioned, was that paralabral cyst, which sometimes, if those can get very large, obviously can start to cause, compression and dyskinetic motion with the iliopsoas. And then lastly, the only other thing I was going to kind of bring up, just more of, topic of discussion, for these cases, is that you guys had kind of put in your report, which was really helpful, that in this case, they didn't have any iliopsoas bursal distension, as well as any iliopsoas tendon tears. And I would say that is the majority of the time as well too, when I've seen these cases, is that sometimes I'll rely on those secondary signs for tendon, related injuries, and that will be, bursal distension, or if there's a tear associated with it. But more often than not, when I've seen these snapping iliopsoas cases, that actually is not the case, that it's just going to be more that kind of dynamic dyskinetic motion that you're going to see. But more often than not, it actually doesn't cause pathological kind of changes to the tendon construct itself, as well as that bursa. But those are kind of the main points. But otherwise, I think you guys did a phenomenal job as far as the protocol, which I thought was, very, comprehensive. So thank you so much.
Thank you.
I just have a quick, oh, go ahead, Maddie.
The only other thing I was going to highlight that I didn't quite talk fully about, like early on when I was kind of reading about this, there's this kind of older school thought about like the iliopectineal imminence being an issue, but it sounds like that's pretty medial and shouldn't really be involved. And it is more of those medial fibers catching and then kind of snapping back into the position in the superior pubic rami. So I don't know if other people are running into that, but that's not really what's going on anymore.
Yeah, in fact, I was going to make that point, Maddie, that that was the old thinking. So nice job that
Oh.
and is really more of a rotational. I just have a couple really quick points. Maddie, Jenny knocked that out of the park. Great images, great presentation. Just a couple quick things. One is, noise and ultrasound when people come with snapping. I find that either it's a very rewarding visit and you're hitting that home run and making the diagnosis, or it's very frustrating where you can feel the snap somewhere and you just can't see it for whatever reason. And I know, and I'm sure the same is for your clinic, that sometimes we have people drive 2 or 3 hours for these ultrasounds. And so we've gotten in the habit actually of calling the patient and asking them if they can reproduce the snapping. Because if they can't reproduce the snapping on demand, it can be really frustrating for everybody involved. And so I find the people that can easily reproduce the snapping wherever it is, oftentimes I would say, 70, 80% of the time we can find the source of it. But if they can't reproduce it, of course, they won't be able to reproduce it in the office. So that's just one comment I want to make. And then the other comment I want to make is that article about iliopsoas anatomy is a really good article. And if you're doing a lot of hip injections and scanning the anterior hip, that's worth reviewing and getting familiar with it, because the iliopsoas complex anatomy is variable. And it can easily be mistaken for an iliopsoas tendinopathy, for example, if you're not sure of what is normal and what's not normal. And so you have to know what's normal is before you can understand the variation. So understanding the different parts of the iliopsoas complex is important. And then my last comment is that when we do a hip injection, obviously it's part of our anterior hip diagnostic exam, but when we do an anterior hip injection, we are looking at the iliopsoas complex on short axis. And I always have my sonographers do a proximal to distal, at least survey. And the reason is sometimes the iliopsoas bursa, the distal edge of the bursa is proximal to the joint. And so you can get your images of the hip joint and miss an iliopsoas bursa. And it's really embarrassing when you say, well, gosh, I don't see anything. And then they get an MR and there's an iliopsoas bursa there. And it's like, oh, whoops. And so it's just become a habit for me to always scan proximal to distal short axis, surveying the iliopsoas complex and looking for a bursa. So that's the only complex. Only other comment I would make is if you're doing a lot of hip injections, make sure you just do a proximal to distal short axis sweep of the iliopsoas complex. But Derek, if you're still on, we'd love to hear any pearls from you.
Yeah, so just to add on to that, Doug, that's a really good point. And I will just mention too, with that bursa can sometimes be sneaky, and you may see the fluid, depending on the patient's position and their anatomy, you may see the fluid more medially oriented. So you look for that tendon lift, but it can kind of hide over in that area deep to the neurovascular structures and can get easily confused or missed as just thinking it's part of muscle fibers of, Pectineus or whatever. So just taking the extra second, like Doug mentioned, to move up and proximal distal, and then also just orient your transducer appropriately to clear that area up, just to make sure that you're not seeing anything over in that region. Yeah, but otherwise, great job. Complex area, like Doug said, these snapping things can be exceptionally rewarding or very frustrating. I think early in my career, I used to really like these because I thought they were fun and exciting. Now I roll my eyes more often because sometimes they can be very challenging. But to Doug's point, if they can't reproduce it reliably or they don't describe their symptoms well, it can be really hard. But just remember that the full differential, sometimes you have to go on an odyssey around the entire hip, because sometimes these loud snaps, especially in the young, like adolescent females, who are a big majority of these, they're very tiny oftentimes, and that reverberating snap is very difficult for everyone in the room to tell exactly where it's coming from. So So remember, there can be sources laterally, posteriorly. You may have to think outside of the box a little bit. But if you can get them to reliably reproduce it, I would agree with Doug. I mean, you're probably 80+% able to identify it if you take the time and really understand your anatomy, which is complex here. So, but no, great job. Yeah, nothing else on my end.
You know, there is one other thing that came up when I was watching this presentation. And Derek, I know you and I have talked about this way back, and that is the iliocapsularis muscle. And when I looked at the radiographs and saw signs of uncovering and cam impingement and et cetera, the iliocapsularis muscle oftentimes is more prominent in these people for whatever reason. It develops differently. And so it's just worth mentioning because in a patient like this, you may see a fairly prominent iliocapsularis muscle, which is a very thin muscle that's going to be between the iliopectineal ligament or the anterior capsule and the iliopsoas.
Yeah, that's a great point, Doug. That my fellows are both laughing right now because I did mention the iliocapsularis to them and told them not to worry about it because I think only you and I are going to care this morning. But it is interesting, right? It's an interesting thing. It's something that you might see, and its role in some of these, hip cases, I think is certainly undefined. But it is interesting. You will see differences here in that population. So it's something that's everyone's homework for the weekend is go find out what and where the iliocapsularis lives and take a look at it. You'll be surprised you've been seeing it in nearly every one of your hip scans and probably didn't recognize it was there.
Yeah, nice job, Maddie and Jen.
Yeah, and thank you so much for the comments, Doug and Maderick. And I think just kind of piggyback off what you guys were saying as far as the motion and reproduction is, once again, I would just put that in the report though. If you cannot reproduce those symptoms for the patient that's coming in, obviously it's going to be very important to know. And so if that is the case, obviously it's unsatisfying, but at least, put it in the report that you weren't able to reproduce those snapping symptoms for that patient. And then just to kind of piggy off what Doug had said, yeah, the article is a really great one for the iliopsoas snapping tendon. And so that's going to be from, just for anyone listening, Dislandis, and that was in the Journal of AJR from 2008. If anyone wants to kind of look up that for a reference. One thing I was going to then, I guess, Doug and Maderick, you guys are still on the call with these cases. I mean, what brought up, do you guys ever see that much like bursal distension or any type of, actually iliopsoas tendon pathology for these cases in your guys' experience? Or usually is it just the snapping component that you see?
So I would say that it kind of goes into two categories. And so in the young, like the young population, whatever, I mean, less than 18, certainly less than 16 for sure. It's pretty rare for me to see much here. Usually it's a painless snap. And I would say it's 50-50 on if it's actually bothersome. If you can kind of tell folks this is normal anatomy and everything looks fine, oftentimes you find out it really isn't all that painful. It's just alarming because they're not sure what's happening. As athletes start to get, or patients start to get older, I will say that I've seen some rather significant both tendinosis and bursal effusions in some athletes here. And so in particular, I've had a few field hockey players, I think something to do with their sport. They've kind of had some gnarly findings here. I've had some soccer players with some stuff here with some legit things, but these have usually been athletes who've been, kind of playing a whole season on a bad hip and have really beat it up. So I think it takes a lot to really start to develop some symptomatology here. The other thing just to remember is you can get iliopsoas pathology further distal, right? So we're visualizing where it comes across the anterior aspect of the hip joint, where we think we're getting most of our, friction type symptoms and such. But it does insert further distal, right? And it's a little bit of a tricky area sometimes to fully evaluate with ultrasound. It's something, again, add to your homework list to go practice actually viewing that. But you can get avulsions down there. I've seen calcifications down there, and it can be associated with some more ominous pathology as well. So just remember that there can be some stuff down there. And then obviously once the hip joint gets involved, you start having labral tears or osteoarthritis in your older patients, then you'll have a much higher risk of seeing iliopsoas bursal fluid distension, oftentimes related to the hip joint. So other pearls, Doug?
No, I mean, I would agree. Hey, Derek, have you ever seen, because I have not, have you ever seen a snapping hip post-arthroplasty? I mean, we get all sorts of beat up labrums, beat up iliopsoas tendons that can happen with arthroplasties, but I've never actually seen a snapping hip. Have you?
Yeah, maybe like a soft call snap. And so I've seen some that are hung up so bad that they kind of pseudo snap, not the dramatic stuff like we saw here, but I've seen it actually more of a medial to lateral. But the patient's so painful you can't really reproduce it. And the tendon usually just starts to rub and you get pretty significant tendinosis findings. But I don't have a great video of a big snap there. I mean, usually it's just a lot of pain.
Yeah, and it wouldn't be a muscle rotation. It would be literally that the tendon is hung up at that, native bone acetabular prosthetic interface. But yeah, I would agree. I haven't actually seen a true snap post arthroplasty.
Yeah. Yeah, definitely not in the way we just described it for sure.
All
Doug,
right.
on sorry,
All
on,
right,
on
yeah,
the post arthroplasty, Doug, I've had patients who have worn out part of their liner that have subluxation of their kind of femoral component. And so like they'll have to stand and go into hip extension and there'll be anterior subluxation of the femoral portion. You can see that snap forward, but they have to be standing and kind of leaning. It's a little bit of an awkward scan.
Huh. That's interesting. And so sonographically, Brendan, what actually are you seeing?
You see like it's very similar to when you see the iliopsoas drop down to the ilium, where it's kind of just like an abrupt motion. It's the same thing, but with the femoral component of the arthroplasty. And so the patient will kind of like have almost an apprehension, and then all of a sudden you see the femoral component snap forward very suddenly.
Wow.
I had to image it from posterior to see it. So you see it like shift away from you essentially.
Sure, sure. Huh, interesting. That's a great case.
All right. Well, unless there is any other comments, thank you so much, Doug, Derek, and Brennan. And once again, Jen and Maddie, you guys did an awesome presentation today. So thank you so much. And then we'll have another case presentation again in 2 weeks. That will be from the Sports Medicine Fellows at the University of Pittsburgh Medical Center, and they'll be presenting a case on a rectus femoris injury. So thank you so much.
Thank you.
Bye.